5,900.
Good noon and warm welcome, everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for a panel discussion on building advocacy for bladder cancer in India. Voice of Healthcare, along with our supporting partner, Pfizer, has taken an initiative to bring together the experts and speakers to recognize Bladder Cancer Awareness Month. This panel discussion aims to shed light on the importance of building advocacy, creating awareness, and fostering collaborations among stakeholders to improve prevention, early detection, and treatment outcomes. Bladder cancer is the ninth most common cancer worldwide, and in India, its prevalence is on the rise. It affects both men and women, with men being more susceptible. The impact of bladder cancer goes beyond the physical and emotional toll on patients and their families. It also possesses a considerable economic burden on healthcare system and society as a whole. So without further ado, let's get started with the introduction of our esteemed panelists today. I welcome Dr. K. Madan Gopal, former senior consultant, NITI Aayog. Welcome, Dr. Gopal. Dr. Amit Joshi, Professor, Department of Medical Oncology, Tata Memorial Center, Mumbai. Welcome, Dr. Joshi. Dr. Boman Dhabhar, Director, Oncology, Fortis Hospital, Mulund. Welcome, Dr. Dhabhar. Mr. Sanjeev Sharma, Director, Bladder Cancer, India. Welcome, Dr. Sharma. So starting with the discussion, my first question is to Dr. Joshi. So what are the current challenges that the patient with bladder cancer face in India?
So I think the most important challenge is the late presentation of the disease, because but still in the case of bladder tumor, the probable positive point is that patients usually present with hematuria. So because of the hematuria, many of the patients present with their treating at least the general physician MBBS, then they can refer. So the most important thing is we have to make sure that whosoever presents with a complaint of hematuria, that should be evaluated. That the probable causes can range from a benign condition like a stone to a malignant condition like bladder tumor or a kidney tumor. So I think that message has to be given to the primary physician and the general population that hematuria needs to be investigated. It should not be looked as any minor event and should not be ignored. So in our setting, still 40-50% patient may still present in a early bladder stage, and few of them present in a stent. But still, that early stage number is not that bad compared to the other malignancy because of the early symptoms.
Right, sir. So you have mentioned that early diagnosis is the mainstay. If we can diagnose the disease early, then the outcomes and the prognosis will become better in case of bladder cancer. And usually, people don't present with these early symptoms, and the doctors also have to evaluate and see each and every aspect of the hematuria that you have mentioned. Moving on to that, Dr. Dhabhar, sir, how can patient data, including outcomes and experiences, be collected and utilized to inform research, policy decisions, and quality improvement efforts in bladder cancer care? Dr. Boman, you are there?
Hello.
Yes, sir. Can you hear me? You are on mute, sir. You are on mute, sir. Yeah.
Can you hear me? Hello?
Yes, sir. I can hear you now, sir.
Okay. So it's always very good to keep the data of the patient. By that, we know the whole chronology of the disease, by which we'll know in our country which type of bladder cancers are more common. Is it superficial or is it invasive? What is the natural history that this bladder cancer of our patient is going to do? So it'll be a very good thing to keep the data. But at the same time, what we should know that keeping the data, keeping a good follow-up is not very easy in practice. What we see, patients may come to you after some time, they'll be going back to the urologist, they'll be going there. So unless it's a big institution, it will be very, very difficult to keep a proper data of the whole patient. So in practice, it's very difficult to keep a data, and many times there are patients who are lost to follow up. Even a big institution, Dr. Amit Joshi can correct me, there will be patients who may come for one or two opinion from Tata, and then they may go to back to their place. So it's always good to keep a data, but it's very difficult in practice. That much I can tell you. And keeping the data will, of course, will help us for a lot of policy decisions, lot of how our patients would behave, how our continent patients would behave, because malignancy, as you know, like in lung, it's different. Malignancy in India, in Asian countries, we see 30 to 40% mutation. So how much is in our country, which type of bladder cancer is common, everything will come to know. And when a patient comes to us, we can tell them much more better, much more confidently that how are they going to behave.
Yes, sir. So what I get from your point is that data is very important to foresee how the outcome of the patient will be. And apart from that, a majority of patients are not consistent with the same doctor. This is what I get, what you've said. And so, Dr. Dabbar, you mentioned about the consistency and the data. So, what other challenges do you feel as a doctor are there in bladder cancer setting?
Many times, it's since it's an hematuria which would come up. So patients would first report to the doctor. They may go to the general practitioners. They may say, "Yeah, it's an infection." Then the things are forgotten for a very prolonged period of time. Then again, when they come and then when they visit a urologist, the things are picked up. Cystoscopy are done. Then they do a biopsy. Then the patient goes. Classically, what happens? I'm telling you, BCG installations. Then after a prolonged period of time, when the disease becomes invasive, they may come to us, or many times it is just forgotten because the patient may not have symptoms. So those are many challenges, and patients travel all the way many times from far off places. So it's very difficult for them to stay in a big city for a prolonged period of time. For regular follow-ups, BCG installations, or whatever. Chemotherapy. By the time they come to us, they have spent quite a number of visits, and they have spent a lot of money and all the other things. So those are very frequent challenges that we see treating these patients, and some of them may be in a very poor health for even giving them chemotherapy because their kidney functions are not proper. So giving chemotherapy will be so difficult many times.
Right. Thank you so much, Dr. Dabbar, for
These
elaborating
are
the
these are quite
challenges.
often challenges that we see in practice.
Right, right, right. Thank you so much, Dr. Dabbar, for mentioning all the challenges as a doctor that you face during the treatment of bladder cancer. So you have mentioned that some patients have to travel so far from their original places, and they have to come for the treatment. So building on to that, Dr. Gopal, I would like to ask you, so what are the barriers to accessing affordable and quality bladder cancer treatment in India, and how they can be addressed?
Thank you, Ritika. Thanks for this opportunity. I've recently transited from NITI Aayog and joined the National Health Systems Resource Center as strategic advisor for public health. So that's one thing which I want to update you. You have raised a very pertinent
Congratulations, sir.
question. Thank you very much. One very pertinent question. One of the barriers for any cancer, including this bladder cancer, is awareness of the population, as mentioned by our previous speakers. That means the presentation is very late. That means very less options are available for at least increasing or prolonging or at least making the life of the person disease free. It's very difficult because if the person is presenting late, that main factor is awareness. Second is the financial barrier, because the other aspect is there in the rural areas, cancer is available, major financial barrier. And apart from that, the insurance products which are there, are they able to cater to this? One is awareness, early diagnostic and prompt treatment. That's the standard thing which we do in public health. Second thing is the availability of the specialized care in the rural and the far-flung areas. We do have a network of institutions right up to a village level. At the village level, we are having an extension worker in the form of ASHA workers, and above them is a health and wellness center where the actual population-based screening is now being planned and is happening. But the main screening is happening for the breast cancer, the cervical cancer, and the oral cancers. But it is not a priority there. So we have to simply devise an algorithm. That means availability of tools for capacitating the workers who are at the scene to screen the population with the help of a simple tool to ask that whether the person is passing blood in the urine or not. If that kind of simple tools are available, at least they can refer the person to the higher level. At the higher level, the other challenge, other barrier is the capacities which are available in the institute, right in the block level or at the district level also. We don't have that kind of trained persons who can at least diagnose this disease and put the person and take a call how what kind of line of treatment is to be given to them, and have proper linkages or linkage with the higher facility, the cancer facilities. That's another barrier, because even if I diagnose things after building capacities at the block level or the district level, if I am not able to refer that person or link that person to a proper cancer specialist, then whole of the loop of continuum of care is not complete. So these are the few of the barriers and the challenges. But the interesting thing is that uh, as we have pushing for the health and wellness centers, so we have upgraded most of the sub health centers, which caters to a population of 3,000 to 5,000, and similar kind of setup has also come up in the urban areas. At that you would be having a person, if we can equip them for screening, so you would be having lot of screening happening, and at least proper referral can happen. That to address these barriers we are trying to do that, but the important thing is how to address the awareness issues. We have to make people aware based on the symptoms. That's the biggest challenge. If the people are aware, they will come to the system. Now people in the urban areas, even as a small things, they usually come to the system and get themselves screened. They will demand the doctor to screen them for particular thing, but the thing doesn't happen in the other part, the rural areas, the tier 2 tier 3 cities. They think that the treatment is expensive, the system is expensive, and they don't want to go to the highest level and see that the accessibility, affordability of these diagnostics and the screening facilities are made available right up to the health and wellness center. We can say that work is in progress from the government side, and see how the private also matches the pace in which we are going. I stop here.
Thank you so much, Dr. Gopal. I think you have rightly mentioned that we need a better collaboration between public and private sector in terms of tackling the cancers, for that matter. Any type of cancer for that matter. And so you have mentioned, Dr. Joshi and Dr. Dhabhar also mentioned that the presenting symptoms that are there are not early detected, or we need early detection tool and an algorithm. Apart from that, we also need capacity building in terms of the primary health centers that are there in the inaccessible areas. So moving on to the patient support group, so I would like to ask Mr. Sharma, sir, what strategies can be implemented to support bladder cancer survivors during their post-treatment or treatment journey, including rehabilitation, surveillance, and follow-up care?
Okay. Thank you, Dr. Ritika and Voice of India. बाकी जो हमारे डॉक्टर अमित सर, बोमन सर एंड के मोहन गोपाल सर हैं. सो जैसे सर बात कर रहे थे, गोपाल सर की बहुत जरूरी है, खास के रूरल एरिया में जो चीजों का है. बाहर जो मेट्रो सिटी है वहाँ पे तो बहुत सारे अवेयरनेस भी है और ये सारी चीजें हैं, लेकिन रूरल में बहुत जरूरत है. लेकिन हम सबसे पहले आते हैं, आपने बात किया है रिहेबिलिटेशन का एंड सर्विलांस का, तो उस पे सो एज ए केयर गिवर और एज ए पेशेंट एडवोकेट मुझे लगता है कि कुछ चीज़ों जो पेशेंट को और केयर गिवर को करना बहुत ज़रूरी है, उस पर ध्यान रखना है कि ट्रीटमेंट के टाइम पे सभी लोग बहुत ज़्यादा ध्यान रखते हैं. चाहे वो पेशेंट हो, उनको लगता है जल्दी ठीक होना है तो बहुत ज़्यादा फोकस होता है, जो डॉक्टर बताते हैं बहुत अच्छे तरह से सारी चीज़ें करते हैं. केयर गिवर भी उतने ही शिद्दत से उनके साथ लगे रहते हैं, लेकिन ट्रीटमेंट के बाद शायद कहीं ना कहीं बहुत सारे पेशेंट से मिलते हैं या देखते भी हैं केयर गिवर से, वो चीज़ों में थोड़ी बहुत कमी आती है, क्योंकि उनको लगता है अब तो हम ठीक हो गए हैं चीज़ों का। बट जो खास के हम आज ब्लैडर कैंसर का बात कर रहे हैं, इसमें बहुत ज़रूरी है कुछ चीज़ें जिसका हम बात करेंगे, जैसे कि अस्टोमा बैग, पेल्विक एक्सरसाइज, और जो गिफ्ट किए हुए जो न्यू ब्लैडर, बहुत सारे जो पेशेंट हैं जिनका ब्लैडर का सर्जरी करने के बाद न्यू ब्लैडर लगते हैं, उनको वही बोल सकते हैं कि जो आपका गिफ्ट मिला है उसका ध्यान रखना, और साथ में अपने खान पान का ध्यान रखना। ये रिहेबिलिटेशन के लिए बहुत जरूरी है, ये 4 चीजों जो ये चीजें हैं। बाकी अमित सर एंड डवर सर करेक्ट कर सकते हैं चीजों को। अगर हम सर्विलांस की बात करें, निगरानी की बात करें या फॉलोअप का बात करें, तो वहाँ पे बहुत ज़्यादा ज़रूरी है चीज़ों को ध्यान रखना कि जो आपके डॉक्टर या सिस्टर या जो भी फिजिशियन ट्रीटिंग डॉक्टर हैं, उन्होंने आपको बोला है कि पानी पीना अच्छे से, उसका बहुत ज़्यादा ध्यान रखना है। एक्सरसाइज बहुत ज़रूरी है, जो वॉकिंग एक्सरसाइज और जो चीज़ों आपको बताया गया है उसका चीज़ों का है। यूरिन टेस्ट, बहुत सारे लोग ऐसे होते हैं, जैसे कि सर बोल रहे हैं, रूरल में गांव में जाने के बाद यूरिन टेस्ट की फैसिलिटी नहीं होती है, उनको कभी कभी 15-20 किलोमीटर या 30 किलोमीटर 50 किलोमीटर चल के जाना पड़ता है। लेकिन आप, अगर वो फैसिलिटी नहीं है, फिर भी आप उस चीज को अवेल कीजिए, आप जाइए और कराइए। बहुत जरूरी है आपका यूरिन टेस्ट करते रहना। दूसरी बात है कि जो रेड फ्लैग टैग बोलते हैं ब्लैडर कैंसर में, उसका बहुत ज्यादा ध्यान रखना है, जिसमें कि यूरिन में ब्लड आना, स्टमक पेन होना, साथ में अगर बोन पेन हो रहा है या खांसी आ रही है, और नॉर्मल जो दवाई लेने के बाद या फिर एंटीबायोटिक लेने के बाद भी अगर नहीं जा रही है, तो इमीडिएट आपके ट्रीटिंग डॉक्टर से सलाह लेना चाहिए। और जो अगर आप वेट लॉस हो रहा है, ये सारी चीजें बहुत जरूरी है। और इससे भी इम्पोर्टेंट लगता है कि 2 साल तक, जब तक आपको डॉक्टर फॉलोअप में बुलाते हैं, आपको आते रहना है। 3-3 महीने या 4 महीने जिस तरह से बुलाते हैं, कारण जो हम जितने भी कॉन्फ्रेंस या डॉक्टर के साथ बैठते हैं, सारी चीजें होती है, उसमें बोलते हैं कि ब्लैडर कैंसर में 2 साल तक बीमारी वापस आने की चांसेस ज्यादा रहता है। तो जब भी आपके डॉक्टर बुलाए, आप कहीं भी हो, प्लीज आप अपना फॉलोअप कंटिन्यू रखिए। जी रितिका जी। और सपोर्ट
थैंक यू
ग्रुप
सो
का,
मच।
जी जी,
या आप बोलिए सर।
हाँ, सपोर्ट ग्रुप का बहुत बहुत ज्यादा जरूरत है। और एक्चुअली हम लोग फिजिकल सपोर्ट ग्रुप तो बहुत साल पहले से करते आ रहे हैं, जिसमें अमित सर हमारे मेन रोल में रहे हैं। हम लोगों ने GCDTN से स्टार्ट किया था। और जब कोविड के टाइम पे, जब हम लोग इतने सारी सिस्टम बंद हो गए थे और पेशेंट को जब वापस भेज रहे थे, वो टाइम पे ध्यान आए, बहुत सारे पेशेंट कॉल कर रहे थे कि क्या करना चाहिए, और हमें तो डॉक्टर से मुलाकात नहीं हो पा रही है सर। वो टाइम हम लोगों ने लंग के साथ में लंग कनेक्ट एक स्टार्ट किया था, और ऑन गोइंग अपना ये जूम मीटिंग के थ्रू उनके साथ कनेक्ट चालू किया था। वो टाइम पे इतना नहीं सोचा था कि जितना हम लोगों ने एक्सपेक्ट किया था कि इतने फायदा हो सकते हैं पेशेंट का, उससे कहीं ज्यादा उसमें बेनिफिट हुआ। और इसी के वजह से हम लोग पिछले साल से ब्लैडर कैंसर के भी चालू किए हैं, और आगे चल के बहुत अच्छा करना है। मेन अगर फायदे की बात करें, तो इसमें सबसे बड़ी बात होती है कि अगर एक पेशेंट, डॉक्टर तो बताते हैं सारे पेशेंट के लिए डॉक्टर भगवान है चीजों को, लेकिन जब कोई पेशेंट जाके कोई भी मीटिंग में बोलता है कि मुझे ये प्रॉब्लम था और मैं इससे ठीक हो गया हूँ, और उस चीज सुन के जब वो मीटिंग में 50-100 पेशेंट रहते हैं, तो उनको एक हौसला मिलता है। तो ये बहुत जरूरी है सपोर्ट ग्रुप मीटिंग। रितिका जी, थैंक यू।
थैंक यू सो मच डॉक्टर शर्मा। आई थिंक हमने बिल्कुल सही बोला है कि पेशेंट जब ट्रीटमेंट चल रहा होता है तब पेशेंट बहुत ही हर चीज़ जो डॉक्टर बोलता है वो करता है, बट आफ्टर जब वो ठीक हो जाते हैं उसके बाद दे डोंट टेक केयर ऑफ देमसेल्व्स। एंड I want to congratulate Bladder Cancer India and Lung Connect India that they are doing so much work for the patients जब भी ज़रूरत होती है, and पेशेंट को किसी भी चीज़ की तकलीफ होती है, so you guys are there to help them. So I want to congratulate you on that. So moving on to the strategies, I would like to ask Dr. Joshi sir, what strategies can be implemented to engage primary care physician and general practitioners in early detection and referral of potential bladder cancer cases?
I think the most important thing is the awareness and the regular some sort of a CME should be they should be made aware of the CMEs regarding the early. It's not for bladder cancer. I think it's for all the other important common cancer, that because the ultimately referral is based on their call or their advice for the patients. So all signs of early cancer, for even not for blood cancer, for lung cancer, cervical cancer. So the referral time should be as much as less possible, and the patient should reach to the tertiary care system early. So and definitely, fortunately for kidney cancer and for the bladder cancer, hematuria is the earliest presentation. So patient can be sent to the higher center at a appropriate time. So, but as a policy maker, I think we have a distinguished guest who involves in the National Health Mission also. So there should be some sort of a revision into the policy and the teaching, even the MBBS teaching. They should be also aware about this thing. Unfortunately, the number of cancer cases are increasing. So the teaching from MBBS part and the CMEs, the continuous medical education for a primary care physician may be the appropriate factor for, and definitely the bladder cancer awareness like program will also help in this concern.
Right, sir. Thank you so much, Dr. Joshi. I think you have mentioned a major part of training that is required for MBBS students, and the CME that can be conducted around this for the doctors, the physicians, and the general practitioners that are there. Moving on to Dr. Gopal, sir, what are the current gaps that you see in bladder cancer advocacy in India, and how can these gaps be addressed, sir?
One of the gap which I can see is the awareness. It's not a priority for in the program, national program. Though all cancer detections are there, but bladder detection of bladder cancer is not a priority for the physicians as well as the others, because we are focusing on this. For advocacy, you require knowledge, and you require that the person, the physician or the caregiver or the provider, healthcare provider, they need to be aware that this cancer also exists, so that they can advocate the patients to come forward. Gap which is there for doing the advocacy is everything is happening in silos. It has to become a movement. That means it has to become a people movement, that people should come forward and screen themselves for not this cancer, for all other cancers. Because why it is important? Uh, you see how many hospital beds we are having. We are having around 15 lakh hospital beds in the country. 20% is ICU beds, around 2 lakh, 3 lakh ICU beds. And if all the beds, whatever number of beds and other things are being created, uh, what will happen if all the people are requiring the beds? Are they adequate? Even if you create next day 1 lakh beds, they won't be adequate. You have to focus and invest more into the preventive aspect. That here comes the role of the Health and Wellness Center, which is under the Ayushman Bharat, as the previous speaker has also mentioned. that the national health mission should take lead. It has already taken lead, and we are too much focusing on the health as well the wellness aspect. The health promotional activities and other things are also happening. The screening for now presently the screening for three cancer is happening, and if we include an algorithm for the further screening, so I think most of the other cancers can also be part of the screening process. Now this is a major challenge. Otherwise, for doing advocacy, the healthcare providers also need to be aware their capacities need to be built in so that they can at least advocate, ask the patient that if the symptoms are there in the medical parlance, you will only, if you're not aware about a certain problem or symptom, you are likely to miss that the diagnosis for the last many years. So in a clinical teaching, usually say that you have to be very conscious and aware about the particular symptoms and factor. If the doctor is not aware, he won't be able to educate that. It should start from the care providers, then the patient education. So in the patient education aspect also, though in medical colleges, in theory, everything has been taught. During internship, the focus, though we have tried to build in the competency-based curriculum in which the awareness and the knowledge and the skill building happens, but it is going to take time. Simultaneously, the training programs are also happening, but they are also happening in staggered, in the fragmented and silos. We have to see that somebody should come forward and build things across. A network is to be created between the government and the private, so that the common cause, that is the cancer detection and screening of cancer, the increasing the longevity of the person and reducing the disability adjusted life and improving the quality of life of that person. So we have to focus in this direction, and the efforts which we are making from the public in the public sector, I think in the coming days you will see a lot of results in that, because the footfall in the public sector institutions is increasing. Previously, it used to be 40%. Now it has become, in some of the areas, it is around 60% footfalls as compared to the private. Footfalls, I am not talking about the expenditure. Expenditure, though, happens in the private sector and mostly in the tertiary care setting, secondary and tertiary care setting, 75% expenditure. But the footfalls, more or less, utilization, more or less, is now increasing in the public sector also. With the screening and other capacity building initiative, I think in the coming days you will see lot many activities about cancer screening in the country. But the bottom line is how to prevent it. The focus should be on prevention, because even if you invest and create more beds and institutions, that is not going to happen. That will at least deter the efforts which we are making. I will stop here. Thank you very much.
Thank you so much, Dr. Gopal. I think you have very rightly highlighted the importance of early detection and awareness. That you said that everything is happening in silos and people are not aware about it. So I think the major role is regarding the awareness is not there in the people, in the patients, that they are suffering from a certain disease. Dr. Joshi has also mentioned regarding the hematuria that these signs and symptoms are taken very lightly. And you also have highlighted the importance of the training, capacity building and training. So moving on to Mr. Sharma, sir, आपके according, what do you think are the challenges that the patient face as a support group? आपके पास patients आते होंगे, so what do you think are their challenges with respect to bladder cancer?
So अगर पेशेंट का अगर बात बोल रहे हैं आप रितिका जी, तो चैलेंजेस ही चैलेंजेस है. मतलब एक चैलेंजेस नहीं, डे 1 से लेके ट्रीटमेंट से लेके और जब ठीक हो जाते हैं तो उनके पास और भी चैलेंजेस होते हैं. सो बहुत सारे चैलेंजेस है, बट हमें करना क्या चाहिए? मैं वो चीज़ों पे अगर हम एज ए सपोर्ट ग्रुप, हम लोगों को क्या करना चाहिए या सोसाइटी को क्या करना चाहिए और चीज़ों, तो हम एक अवेयरनेस कर सकते हैं, जैसे सर बता रहे हैं. जैसे अब अवेयरनेस की हम लोग यूट्यूब चैनल का बात करते हैं कि हम लोगों ने अभी बहुत सारे वीडियो बनाए हैं ब्लैडर कैंसर रिलेटेड और उसको यूट्यूब पे डाल रहे हैं. तो यूट्यूब का आइडिया क्या है, जब मैं बिल्कुल गांव गए थे और वहां पे बहुत सारे लोगों को देख रहे हैं अभी के तारीख में कि सुनना सबको आता है, पढ़ने आए या नहीं आए। हाँ, तो वो लोग, मैं ऐसे लोग देख रहे हैं कि वो यूट्यूब लगा कर को खाना बना रहे हैं लेकिन यूट्यूब देख रहे हैं। और काम कर रहे हैं यूट्यूब, गांव में देखा ट्रैक्टर चला रहे हैं, सामने यूट्यूब लगा रहे हैं। तो हमें ऐसे ऐसे चीजों को ढूंढना पड़ेगा कि किस तरह से हम ज्यादा से ज्यादा लोगों तक पहुंच सके और अवेयरनेस कर सके। बट इससे हम लोग लोगों को जितना अवेयर करेंगे, जैसे मदन गोपाल सर बोल रहे थे, हमें उस चीजों में लगता है कि एक बहुत ज्यादा जरूरी है कि जो हेल्थ केयर है, प्राइमरी हेल्थ केयर के लोग हैं, वहां पे अगर उनको हम लोग सरकार का काम है, वो सरकार अगर चाहे उनको एजुकेट करें और उस चीजों को, ऑलरेडी वो एजुकेट हैं, लेकिन अगर उनको कैंसर के बारे में ज्यादा जानकारी दिया जाए या आशा वर्कर हैं उनको दिया जाए, तो ये बहुत ज्यादा फायदा हो सकता है चीजों को। अब देखिए, कोई किसी को बोलना आसान है। अगर आज मैं बोल रहा हूँ मुझे भी खांसी हो रही है और 5 दिन 7 दिन या 10 दिन या यूरिन में ब्लड जा रहा है, तो एकाएक लोग ये नहीं सोचते हैं कि हमें कैंसर ही हो जाएगा। हाँ, और अब हमारा सिस्टम ऐसा है कि अगर ऐसे कुछ होते हैं, अगर गांव, हम शहर की बात अलग है, मेट्रो की बात अलग है। गांव में क्या है, पहले एक प्राइमरी में डॉक्टर रहेंगे, उनके पास जाएंगे, फिर उसके बाद वो रेफर करते हैं, तो फिर थोड़ा सा हायर में जाएंगे, फिर डिस्ट्रिक्ट में जाएंगे, और ये सारी चीजों में करते, जैसे बोमन सर भी बोल रहे थे, इतने टाइम निकल जाते हैं ताकि आते आते थर्ड स्टेज और फोर्थ स्टेज हो जाता है। तो हमें अगर बेसिक चीजों पे अगर फोकस करना है, तो हमें प्राइमरी हेल्थ केयर पे फोकस करना पड़ेगा और वहां पे जितने लोग हैं उनको एजुकेट करना पड़ेगा, और जो कैंसर डिजीज है उसे नोटिफाइड डिजीज करना पड़ेगा। ये जितने भी नंबर आते हैं ना, मेरे समझ से इतने ही नंबर नहीं है, बहुत ज्यादा नंबर है। बहुत सारे ऐसे लोग अभी गांव में हैं जो कि शहर तक, डिस्ट्रिक्ट तक भी नहीं पहुंच पाते हैं, और वो वहां पे ही ट्रीटमेंट नहीं ले पाते हैं। तो ये चीजें, तो सपोर्ट ग्रुप एडवोकेसी करना हम लोगों का है कि लोगों तक अवेयरनेस पहुंचाएं। लेकिन आप भी अगर आप कर रहे होंगे मैडम, तो देखते हैं, हम भी यूट्यूब बना के देख रहे हैं, तो क्या है, हमारे यहाँ जब तक हम पे कुछ होता नहीं है तब तक हम उस चीज को सीरियस नहीं लेते हैं। तो लोगों को इस चीज पे ध्यान देना है कि हमें किस तरह से वो वीडियो को देखना है, लेकिन हमें साथ साथ में हम लोगों को करते ही रहना है कि जितने ज्यादा से ज्यादा पेशेंट जुड़े, लोगों तक इस बात को पहुंचाए कि कैंसर क्या है, कैसे होता है। लेकिन एक ही चीज मैं बोलूंगा कि जिस दिन हमारा प्राइमरी हेल्थ केयर सुधर जाएगा, वहां के लोग एक्सपर्ट हो जाएंगे, उस दिन इस चीजों पे हम लोग विजय पा लेंगे।
थैंक यू सो मच मिस्टर शर्मा। आई थिंक आपने बहुत ही अच्छी चीज हाईलाइट की है दैट हमारा प्राइमरी हेल्थ जब इम्प्रूव हो जाएगा, सिस्टम इम्प्रूव हो जाएगा, तो लोग खुद ब खुद आगे आएंगे और डिस्कस करेंगे ये सारी की सारी चीजें। एंड आपने मेंशन किया है कि यूट्यूब के थ्रू कोई भी हो, पढ़ना लिखना नहीं आता हो, बट सुनते सभी हैं। सो इसी प्लेटफॉर्म के माध्यम से मैं, अगर पेशेंट्स हमारे देख रहे हैं ये प्राइमरी टीयर 3 सिटीज में, सो आपके अकॉर्डिंग व्हाट डू यू थिंक हाउ दे कैन रीच patient support groups, how patient support groups help them during their journey with cancer? So can you do you want to tell this to them?
हाँ, अगर कैसे पहुंच सकते हैं, जब तक लोगों को जानकारी नहीं होगा, तो ये बहुत बड़ा सवाल है कि कैसे पहुंचे। तो एक तो जहां पे हमें गूगल का फायदा लेना चाहिए, वहां पे लेना चाहिए कि अगर कहीं भी जाते हैं, तो अगर कोई भी कैंसर, ब्लैडर ही नहीं, कोई भी कैंसर होता है, तो हमें सर्च करना चाहिए कि इनका सपोर्ट ग्रुप कहाँ पे है। और बहुत सारे सपोर्ट ग्रुप है, बाहर के देशों की तरह नहीं, हमारे यहाँ आज भी अनफॉर्चुनेट है कि बहुत कम सपोर्ट ग्रुप है, बहुत कम एडवोकेसी ग्रुप है ये चीजों का, जो कि बाहर देश में बहुत ज्यादा है। अभी शुरू हो रहे हैं धीरे धीरे, और ये आशा है कि बहुत ज्यादा इस चीज पे फोकस होंगे। बट पेशेंट से जो आपने बोला, मैं यही रिक्वेस्ट करना चाहूंगा कि जब भी आपको कैंसर होता है, गूगल पे जाइए, सर्च कीजिए और देखिए कि सपोर्ट ग्रुप, जो भी कैंसर हो उसका सपोर्ट ग्रुप कहाँ है, उनके साथ आप ज्वाइन होइए। सपोर्ट ग्रुप में ज्वाइन होने से एक फायदा तो ये होगा कि वहां पे जब आप अपना कंसर्न डालेंगे तो आपके जैसे बहुत सारे पेशेंट रहेंगे या केयर गिवर रहेंगे, वो आपको आइडिया देंगे और बताएंगे। लेकिन एक चीज इसके साथ में हमें बहुत जरूरी यहाँ पे बोलना आप सभी को है कि सुनिए सभी का, लेकिन ट्रीटमेंट रिलेटेड जब भी कोई बात हो तो आप अपने ट्रीटिंग फिजिशियन का ही सुनिएगा, क्योंकि एक तरह का बीमारी हो सकता है, नाम एक तरह हो सकता है, उसके बहुत सारे अलग ट्रीटमेंट हो सकते हैं, पद्धति हो सकते हैं। तो अगर कोई पेशेंट ट्रीटमेंट लिया होगा, वो बताएगा कि हमें ऐसे 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 हुआ था, ऐसे करो, आप वो चीजों पे ध्यान नहीं दीजिएगा। ये एक बहुत बड़ा चीज है रितिका जी, कि हमें जब भी ध्यान ट्रीटमेंट रिलेटेड सुनना है तो आपका ट्रीटिंग डॉक्टर का सुनना है। बाकी आप मोटिवेशन लीजिए, लोगों से समझिए कि बीमारी क्या है, क्योंकि जब एक कैंसर होता है किसी का भी, किसी भी घर में हो, चाहे कितने भी पढ़े लिखे लोग हों, तो सबको पहला जब भी ये होता है तो दिमाग में ये लगता है कि अब आगे क्या, हमारे जिंदगी में कॉमा लगेंगे, क्वेश्चन मार्क लगेंगे या फुल स्टॉप लगेंगे। तो इस चीज को दूर करने के लिए सपोर्ट ग्रुप है। जब वहां पे जाएंगे और इस चीजों को आप अपना बात को रखेंगे तो आपके जैसे वहां पे 100, कोई ग्रुप में 1000, और हम आशा करते हैं कि कुछ दिनों में सपोर्ट ग्रुप में लाखों लोग रहेंगे जो कि इस चीजों के जो भ्रांति है उसको दूर करेंगे। जी
थैंक यू सो मच मिस्टर शर्मा। आपने बहुत ही सलीके से हर चीज प्रोसेस बताया है जिसके थ्रू पेशेंट्स कैन रीच आउट टू यू। So, Dr. Gopal, I would like to ask you, sir, can you share any specific initiatives or programs that have been implemented to reduce the burden of cancer in our community?
जैसे कि मैंने पहले बताया था कि lot of initiatives have initiated. तो जो main initiative है, we have to see that कि reduction in the incidence of this. We are having an NCD program which talks about treatment, extending the treatment for cancers. और जो दूसरी चीजें हैं, एक तो there are two folds. One is the preventive activities, preventive and screening के लिए. So through health and wellness centers, we are screening the population for cancer and putting them or connecting, referring them to the normal the concerned institutions and putting them on treatment so that continuation of this. उसके अलावा जो कैपेसिटी बिल्डिंग इनिशिएटिव्स है, नेटवर्क इज बीइंग क्रिएटेड विद द हेल्प ऑफ बिग कैंसर इंस्टीट्यूट्स, ताकि वो डिस्ट्रिक्ट एंड बिलो डिस्ट्रिक्ट डॉक्टर्स की ट्रेनिंग कर सकें। एक बार डायग्नोस हो गया है तो फर्दर कंटिन्यूएशन ऑफ ट्रीटमेंट कैन हैपन एट द डिस्ट्रिक्ट। दैट्स अनदर थिंग इज हैपनिंग. So in PMJ program, which caters to around 50 crore population, so in that cancer packages are there, and in that PMJ program, all the hospitals which are participating, they are mandated to have cancer boards in their institute so that the treatment is also streamlined. ये तो हो गई ट्रीटमेंट स्क्रीनिंग की होगी, बट nevertheless we have to see that how the prevention also happens. So lot of efforts are being made to understand the environmental factor which are causing this cancer, because unless and until you prevent, the disease burden and other things is going to increase, and the systems, whatever number of systems you create, that is not adequate to cater to the increasing needs of this. India may we do less than 5% screening of the population, and you see the numbers, staggering numbers are there. If we start doing the screening as been done in the Western countries, where the screening is more than 90%, 95%, do we have adequate beds to cater to that population or not? That's another challenge which we are having. Screening भी बढ़ाएंगे, beds भी बढ़ाएंगे, साथ साथ में if we focus on the preventive aspects, then we can balance it out. Otherwise, the whole of the efforts and the money would be eaten up by this cancer. अब कैंसर का देखिए, एक पेशेंट अगर किसी के घर में कैंसर होता है, with support of everybody, also the family which is there, that gets improvised. That means it falls back into, it lowers the level of that person. अगर कोई गरीब है तो और गरीब हो जाता है, मिडिल क्लास है तो और मिडिल क्लास हो जाता है. 80% of the population जो इंडिया की है, they earn around 40,000 or less than that in a month. तो you have to see that कि how we cater that, और उसके अलावा जो दूसरी चीजें हैं, we are trying to see how a financially viable this insurance product is made available to these people. क्योंकि अभी जो insurance के products and other things, they are not affordable by anybody. Even you and me can't also afford. कि वो कवर भी नहीं होते, अगर कवर होते हैं तो काफी प्रीमियम इतना ज्यादा होता है कि हमारे लोग कवर, हमारी जो आम जनता है जो जितना अफोर्ड कर सकती है, they can afford a premium of 10,000, at the most 12,000 per year. 80% of the population earning less than 40,000. आप सोचिए अगर ऐसे उसमें if you want to, अगर किसी को कैंसर होता है तो family is impoverished and हमारा भी out of pocket spending is 48%. If you want to reduce it and bring it to 20%, you have to invest into the preventive aspects, and we have to see that कि how उसको थोड़ा सा strengthen कर सके. तो यही बोलना चाहूँगा अभी, you have to find a way कि how to further invest into the preventive promotive activities so that the burden of disease also reduces.
Thank you so much, Dr. Gopal. I think you have rightly highlighted the importance of prevention in any disease for that matter. And apart from that, you have also highlighted the importance of figuring out an aspect of insurance into this cancer, that 80% of population are not able to afford it. They are not able to even build up the premium or can take the insurance. And sometimes the cancer coverage is also, most of the time the cancer coverage is not there in some of the insurance packages as well. And you have highlighted the need for prevention. So Dr. Joshi, are you there? We have one
Yes,
question
yes,
from the audience.
yes.
Yes, we have one question from the audience that as Dr. Gopal was also talking about the prevention. So, what are the risk factors that one can look with respect to bladder cancer? So,
I think apart from the risk factor, the most important is the smoking. Like in many other cancer, cigarette smoking is one of the important risk factor. So prevention of smoking doesn't not only prevents the, most importantly, the oral cavity, lung, but apart from this, the other cancers, the bladder cancer is one of the other rare risk factors includes some of the industrial dyes used, they prolong the stone formation in the bladder. That is one of the other. But number one is the smoking. So if we prevent the smoking, definitely the risk of not only the lung, the bladder cancer, but other more common cancer like the lung cancer. And apart from that, the other things like the hypertension, the cardiovascular events, all are so. Prevention of smoking should be one of the important goal from that aspect. The other point which I just regarding the insurance and all that we discussed, that will be request from our side. Whatever we have seen that the insurance coverage, the reimbursement of insurance from the insurance companies, that is very challenging. Sometimes the patient has paid, the family has paid the initial installment for that, but at the time of the recovery of the insurance, the various clause have been put in on the basis of that oral therapy will not be covered. Like this, the patient should take treatment in the incoming, the 24-hour admission is required. So I think from the people who are involved in the policy making, that will be request from our side that these sorts of a clause, we know that there are various good treatment for cancer are in the oral way. If the initial payment has been paid by the family, then why they are denied for the reimbursement on the name of the that this is oral treatment. Many treatment can be carried out on daycare basis that doesn't require admission. So why it is so? I think that some sort of a drastic change in the policy is also very much required in from the insurance IRD and all that. They should be instructed that. So that is the request from our side, that we have, even the patient family has taken the insurance cover, but at the time of insurance there are various clause and all that. So I think that is the request that they should look into that, and all these clause, that whatever the cancer treatment, whether it is oral or a daycare, that all should be concluded, and there should not be discrimination based on that basis.
Rightly said, Dr. Joshi. You have rightly highlighted the pain points of patients in the insurance sector. With this, I would like to conclude the session here. And before concluding the session, I would like to take any concluding remarks from the all the panelists. So, starting with Dr. Gopal, sir, would you like to say something to our audience?
ठीक है कुछ नहीं. Sorry, I was on a call. So this
No
is
worries.
we have to focus on the preventive aspect as the risk factors identified by Dr. Joshi. We see that how we right from identifying the risk factors, focusing on prevention due to these risk factors. Then second thing is how we invest into early detection and diagnosis as people are coming late. Because nowadays in tier 2, tier 3 cities, whatever, if there is hematuria, they usually go for KUB and this diagnostics. That is there, but we should capacitate the people for improving their diagnostic skills and having a higher degree of suspicion for cancer. Then seeing that after doing this, whether the proper referral happens, and this, we have to see that how this loop from prevention to treatment as well as improving the life with the help of support groups and the help groups, which Sharma ji has pointed out. You see that how we complete this loop. The challenge lies here only. Okay, I stop here. Thanks.
Thank you so much, Dr. Gopal. Thank you. Dr. Joshi would like to add something. I think there is some network issue with Dr. Joshi. So, Mr. Sanjeev, आप कुछ ऐड करना चाहते हैं इसमें?
या सो एक्चुअली मदन गोपाल सर हैं यहाँ पे, या जो भी गवर्नमेंट का लोग सुन रहे होंगे, तो हम सारे पेशेंट और केयर गिवर के तरफ से एक अर्ज करना चाहेंगे, रिक्वेस्ट करना चाहेंगे कि जो इंश्योरेंस का बात कर रहे थे अमित सर या पवन सर, बहुत पहले तो डायग्नोस्टिक कवर ही नहीं है इंश्योरेंस, और आज के तारीख में अगर कोई भी डायग्नोस्टिक करने अगर कंफर्म होने जाता है तो लगभग एक 25 से 50 हजार तक चले जाते हैं. सो गरीब लोगों के पास उतने भी नहीं होते. कितने लोगों का सही डायग्नोस्टिक हो पाता होगा, ये एक सोचने की बात है. इसमें बहुत ज्यादा सर ध्यान दीजिएगा. कोई भी इंश्योरेंस वाले, चाहे हमारा बहुत अच्छा गवर्नमेंट कर रही है कि जो आयुष्मान भारत और ये सब कर रही है, बहुत बहुत धन्यवाद, लेकिन ये सारी चीजें भी हमें कहीं कहीं सोचना पड़ेगा कि उसमें कैसे इंक्लूड करें. दूसरी बात है कि कैंसर को सर नोटिफाइड डिजीज करना चाहिए, ताकि कल जाकर कोई इतने अभी कैंसर आ रहे हैं तो हम कैसे इसको हैंडल करें. आप लोग उसको उस पर भी यहाँ पे सोचना है, तो नोटिफाई करेंगे तभी पता चलेगा कि साल में कितने एग्जैक्टली कैंसर पेशेंट हैं. उस चीजों का एक चीज है. दूसरा, जो हम प्रिवेंशन से भी एक चीज और आगे बोलना चाहेंगे सर, कि प्रिवेंशन तो ठीक है, हम कुछ ऐसा क्या करें जिससे कि कैंसर हो ही नहीं. तो उस पर एक सोचने की जरूरत है कि अभी शुरुआत करेंगे तो शायद 15 साल लगेंगे, 10-15 साल, तो हमारे जो नेक्स्ट जनरेशन है उनके लिए फायदा होगा. तो कुछ इस पे करना चाहिए. और सारे पेशेंट और केयर गिवर को बोलेंगे कि जहां भी सपोर्ट ग्रुप है, चाहे कोई भी डिजीज रिलेटेड है, आप लोग जरूर ज्वाइन कीजिएगा. उसमें जाने से आपको बहुत ज्यादा फायदा होगा, आपका मनोबल बढ़ेगा, आपको मोटिवेशन मिलेगा, और उसका हमने नाम रखा है कि केयर एंड शेयर. आप भी उसको कीजिए अच्छे से और शेयर भी कीजिए. और आपके लगभग डॉक्टर से पूछिए, गूगल में सर्च कीजिए कि कहाँ पे इस तरह का सपोर्ट ग्रुप है. इंडिया का है, इंडिया में जुड़िए, फॉरेन का है, फॉरेन में जुड़िए, और प्लीज सपोर्ट ग्रुप में जरूर जुड़िएगा. थैंक यू.
Thank you so much, Mr. Sharma. So, with this, I would like to conclude this session here. So, I would like to thank all the panelists, esteemed panelists, for taking time for this critical discussion today. This discussion has been very informative and insightful and provided valuable insight into this critical issue. So, thank you so much, Mr. Sanjeev, Dr. Gopal, Dr. Dhabhar, Dr. Joshi. Thank you so much for joining us for this discussion today.